All right, welcome to Experiential Lab number 1 from the S1R1 manual on page 22, Basic Postural Assessment. So, why is posture important? What things do we need to know about posture that are going to influence our movement? Yes, those are questions for you. So posture helps with the organ system inside and keeping that in good alignment and good function. And then also you said that it doesn't place stress on certain structures throughout the day, right?
There's endurance. If you're in good posture, you can sit long, standing longer. Neutral positions are important to learn, so you don't get injuries.
Right. So prevention of injuries, being in good postural alignment throughout the day for long periods of time, being able to stand for long periods of time and being able to sit for long periods of time is usually required in any job. So you think of a clerk at Macy's. They have to stand for long periods of time throughout the day, and how would they be able to do that in poor postural alignment, and what structures would be stressed if they did? And what about a secretary who has to sit for hours and hours a day? Typing, answering the phone, doing desk work. It's going to certainly be important to have good postural alignment while you're doing those activities. How does posture influence movement and or function?
How you need to without compromising something else.
Right, so if you have poor posture, then you could be compromising other structures. So if you had a rounded back, as you were showing, reaching forward, you could have shoulder impingement. And if your head is forward also, you could have headaches from the suboccipital space being encroached upon. And then you get the nerve root irritation that causes some migraines and headaches. Okay, very good. So how do the Polestar principles influence posture? Remember what those principles are: breathing, axial elongation and core control, spine articulation, head, neck, and shoulder organization, weight bearing and alignment of the lower extremities, and then movement integration. How do those influence posture? Are they components of posture? Yes, they're all components of posture. And being able to hold your body in space. So what does breathing have to do with posture? Yeah, some people think that breathing actually has a great influence on posture and the shape of the rib cage and how we hold our body. So somebody with a chest that's prominent, like a bird breast chest or flat thoracic spine, is probably an upper thoracic breather. So it would be more a person that would utilize more pump handle breathing. Now, another person might also be an upper thoracic breather, but they're more posterior upper thoracic breather. If somebody's very kyphotic, the place that they end up breathing is back here. So if I could facilitate them to breathe more anteriorly, that could influence their posture. So if someone had a scoliotic curve, I might have them breathe into the concave side to see if I can give them more support to their spine. So those are how, and core control. It's like if we don't understand core control and how to hold ourselves up in space all day long, then we're ending up holding ourselves up with our back extensors. So certainly those principles of understanding core control and really how to use it are going to be important in influencing posture. And so what do you think you need to know to be able to assess posture? How do you know if somebody's in good posture?
Observation.
Observation skills. You need to be able to see alignment, yeah? What else you need to know to be able to assess it?
Do they have pain after sitting a long time or standing a long time? So
right. Are they comfortable in their posture? Is there pain when they stand or sit for long periods of time? What else do you need to know? So if you were going to tell somebody about someone else's posture, so you had a colleague that you were going on vacation and you wanted them to see your client, what would you have to tell them in order to have them work with that client's posture?
If they have any structural issues, like someone who has scoliosis, like they have.
How would you describe that? How do you? So you need to know how to describe those postural deviations. You need to know what's normal and what's good, and then to be able to identify what's not so good and not normal. Yeah.
So you could say increase lumbar lordosis.
Right. Yeah. So you're going to need some anatomical terminology to describe the spine, to describe the shoulder girdle position, to describe the head position, to describe knee and pelvic alignment. So you need to know what an anterior tilt of the pelvis is versus posterior tilt. So you need some terminology to be able to describe what you see. So that's some of the things that we're going to be looking at today in our posture lab. All right, let me invite Christy over, and we're going to start to look at some of these landmarks in her body, and you'll be able to find those landmarks in each other as we go along. Okay, so stand facing the back, and first we're going to find the occiput, and a good way to do it is to find the mastoid process at the base of the earlobes, and then walk up the base of the skull. You're going to feel those spine extensor muscles kind of sticking out there, and go all the way up, and you're almost in the place where you're in the middle of the ear, pretty much even with her nose. And that's where you're going to find the little bump called the occipital protuberance. And the occipital bone is actually back in the posterior aspect of the head. So some people have a bumpier one than others. Hers is fairly flat, but there is a pointy structure there. And some are easier to feel than others. Okay, so that's the occiput. The next is the transverse process of C1. So you're going to go back to the mastoid process here, go just in front of it. And right there is where the mastoid process is. So go ahead and bend side to side. And as she bends from side to side, as she bends to the left, the transverse process will stick out on the left. As she bends to the right, the transverse process will stick into your finger on the right. The C1 vertebrae is like a washer at the base of the skull. And it's quite large. It's amazing how far those transverse processes stick out. And so you'll be able to appreciate that right underneath the earlobe there. Okay, and the next landmark is C2. So it's pretty easy to feel because if you go to the occipital protuberance and you go down, there's a space where you sink in, and that's where C1 actually is, but you can't feel it because it's pretty deep in there. And if you keep going down, you'll come to the top of C2 and you'll find a little ridge and a little protuberance there. So that would be C2. The next bony landmark I want you to find is C7. So C7 is actually at the base of your neck. And if you put your fingers on the largest bump at the base of the neck and then one finger above it, have the person look up towards the ceiling. And if the vertebrae under your index finger moves away from you or sinks and disappears, then you're on C6. And the vertebrae that stays still is C7. Okay, so that's usually the biggest bump at the base of the neck, but it's not always the biggest one. So don't assume that it's always the biggest one. Just put your fingers on the big bump and then put your index finger on the bump above. See if that bump moves. If it does, then it's C6. So for Christy, that is C7 there. Okay, the next spinous process is T1, which would be right below C7, and that's where the ribs begin to attach. Like a collar around the base of the neck, it attaches to T1. Coming down to the spine of the scapula, you can feel the spine of the scapula as it comes across the upper back. And then at that superior angle of the scapula, you'll go right across there, and that should be at the level of T2. Depending on if someone has elevated shoulders or excessively depressed shoulders, it might not be at the level of T2. So if you find your T1 and you go to the next bump down, that's T2. And again, that superior angle of the scapula should be right at the level of T2. And in Christy it is. That looks really good. Okay. And the acromion. So let's go. We've found the spine of the scapula, and if we follow it all the way across, I always imagine that the scapula is like the continent of Africa. And you see that the inferior angle of the scapula is the Cape of Good Hope, and then this is the Atlas mountain range at the top, and then you come over to the west coast here and feel the acromion. It's like a little pointy bone at the outside edge of the shoulder, and then just below it will be the humeral head. You'll see that, and you can feel the flat acromion across the top, and it's usually about 1 inch long there. Okay, so coming back across to the spine of the scapula, we're going to go down the medial border of the scapula and find the inferior angle of the scapula there. And then it's real hard to find the lateral border of the scapula, but if I hold on to it there, sometimes just grabbing it there and having it move back and forth, you can feel the lateral border of the scapula, but there's a lot of meat over it. So you feel the teres major is over the top of that. Okay, our next landmark is T4, and I want to find T12 and then L3. So remember we had T2 just across from the superior angle of the scapula, which would be about right there. And I can confirm that, again, going back to T1 and looking up. There we go. So that would be T1, this is T2, T3. T4 is usually right in the middle of the scapula. And then T7 is usually right at the inferior angle of the scapula. So her T7 is going to be about right there. You can always count down too. You can count the bones down. But we like those relationships so that we can find these bones very easily. Now we'll look at the relationship of the ribs to the pelvis. And often I stick my fingers in here and see if I can feel the 10th rib that comes around. And just below that would be the iliac crest. And just in front of my fingers would be the 11th rib, or excuse me, just behind my fingers would be the 11th rib, where it comes out, and if I pull back a little bit, I can feel that rib coming around. It's the floating rib. And then the 12th rib is going to be about as long as your thumb, and it's going to be underneath this thick layer of muscles. When I stick my fingers in here, what's above my fingers, so I can get about 4 fingers in there, between her ribs and pelvis, what I'm feeling above there is the 10th rib. Yep, and so there's about 4 fingers different distance between the 10th rib and the iliac crest. Okay, now another landmark that we wanted to feel was the 7th rib, which is a little tricky. So I'm going to cheat, and I'm going to go back to the inferior angle of the scapula. I'm going to go straight across, and I'm going to find T7. Okay, and then I'm going to feel, I know that the ribs angle downward here. So I'm going to feel outward from here, and there we go. There's the 7th rib, and it goes all the way around and across to the front. So you want to feel that rib, put your thumbs on it, and be able to drag your fingers across that rib. Okay? All right. Now, going back to the iliac crest, and then to the PSIS. This is easier to feel in other people, in some people, and harder in others. So if I find the pointy bits at the base of the lumbar spine, sometimes there's dimples there in some people, and for her, those are easy to feel. And at the level of the PSIS is usually what we call S2. It's the second bump of the sacrum. So if I want to find L5, it's pretty simple to come across to S2, and I know that S1 is just above that, and then L5 is going to be just above that. So now arch your pelvis into an anterior tilt. And if I'm truly on L5, I will keep feeling the sacrum here on this finger, and my thumb will feel the L5 move forward. Okay, and then come back down. So the easy place to find that is to start by finding the PSIS, come across to S2, and then go up a vertebrae to L1, and then go up one more to L5. And then you can have them move into an anterior posterior tilt to make sure that you're there. Okay, and now our next landmark, let's see if there's any other posterior ones. Okay, so let's go around to the front and we'll find the ASIS. Okay, so we found the PSIS, and the PSIS is generally a little bit higher than the ASIS. And remember, the sacrum sits at an angle so that the promontory of the sacrum is not level, it's actually angled forward. Okay, so the same as the pelvis. So we find the ASIS bones here, and then we can turn to the side and see that truly her ASIS is a little bit lower than her PSIS. Now if I have her try to level those out, because some people think that you're supposed to have those level, you see that that puts her in a tuck position, and she has to squeeze her buttocks in order to make that happen. But that also flattens out her lumbar spine quite a bit. So we don't want that. We want that slight anterior tilt of the ASIS just a little bit lower than the PSIS. Okay? All right, and then from here I can go straight down and find the greater trochanter. Another way to find it that's a little bit easier than other ways is to put your hands on the biggest bump on the outside of the pelvis, and then have the client flip their foot in and out, rotating the thigh in and out. So you can separate your feet a little bit, and then flip your foot in and out, letting your legs internally and externally rotate. Just do one side. It's easier. Yeah, there you go. And just go quickly. And so you'll feel that bone flip underneath your fingers, and even faster. That's it, and just really let the bones move. And 1, and 2, and 3, and 4, go fast. That's it. So sometimes making them do it really fast is actually easier to feel. Okay. I'm going to wait on the psoas for a moment because we're going to have her sit down to do that. We found L5, we found S1, we've seen the sacrum, and the coccyx would be easier to feel in prone as well. And then the fulcrum point of the hip is also where the head of the femur is. So the fulcrum can be this way. So if I put my hands on the greater trochanter and have her sit as if she's going to sit in a chair, so do a little squat, I'm going to see that that's where the hip hinges. And that's what we call the fulcrum point of the hip. Now if she was going to do abduction, I might put my hand in the front of the pelvis and then have that be the fulcrum point of where the hip moves. So generally we're talking about with a sit to stand action. Okay, and then moving down to the knee, so we're going to have you face forward. We go to the lateral and medial condyle of the knee. And first I like to find the patella. And so there is the patella, and the top of the patella is going to be just in front of the condyles of the knee. So easiest way to find the condyles, I think, is to find the medial and lateral joint lines, and then you know that when you're the bones that are above that are the medial and lateral condyles. Okay, so let's have you sit down, and we can also find the psoas here in sitting too. And then when she flexes and bends her knees to a 90-degree angle, the base of the patella is likely at the joint line. So if I find the base of the patella and hold my fingers like a saddle around the knee, then when she flips in and out, then I'm going to feel the seams of the knee, of the tibia, yeah, move in and out. So if I have my hands on the tibial plateau here, I can feel the medial and lateral joint line. Above that is the condyle, the medial condyle and the lateral condyle of the femur. Okay, so it's like I'd like to talk about that as the dishes. The tibial plateau is like the dish that holds the condyles of the femur, and the meniscus is what cushions the dishes and keeps the knee congruent. All right, the tibial plateau or the tibial tuberosity is an easy place to feel in some people. She has a nice prominent one there, and that's where the patella tendon inserts. Okay, let's find the fibular head. So if I go to the outside here, and I'm going to stay with the joint line. If I go to the joint line, I'm above the fibular head. I need to slide down a little bit and go to the fibular head, and I'm going to put my fingers around it. Hold on to her thigh. Now flip your foot in and out again, and I'll feel the fibular head roll underneath my fingers. Great. Okay. I can also feel the fibular head glide up and down when she dorsiflexes and plantar flexes. So dorsiflex and plantar flex. And dorsiflex and plantar flex. That's often a problem with the knee or with the ankle even when the fibular head doesn't glide appropriately during walking. Okay? Now let's go to the talus. I love finding the talus. I think it tells us so much about what's happening in the foot and where people are weight bearing in their foot. So if I have her lift her toes up, I'm going to see the tendon of the extensor digitorum come up. And if I have her dorsiflex her foot a little bit, take it off the ground, yeah, I'm going to see that the anterior tibialis tendon also contracts. And so if I grab behind that tendon, those two tendons, and then place your foot back down, I'm going to be right on the talus. So if I have you roll to pronation and then supination, what I will feel, move my fingers, is I'll feel the head of the talus roll in and out underneath my fingers. And what I want is what we call subtalar neutral. Okay? So if I feel the talus here and I feel both sides equally under my fingers, then I know that she's in a neutral position. If she's pronated, I'm going to feel this side of the talus under my finger more. If she's supinated, I'm going to feel this side. Okay, so what I want is to be able to identify that so that when I'm doing footwork or any exercise in the Pilates studio, that I know how to organize the foot into that neutral alignment. Okay, and then the calcaneus, again, that's a simple one. You can, let's keep you there. You can hold on to the heel And I like to see how the calcaneus moves when we bring her into supination and pronation. So lift the leg in front of you a little bit, and then you're going to feel the calcaneus invert and evert. That's right. Yes, exactly. Okay. All right, and then back down. The metatarsals, basically the first metatarsal articulates with the first cuneiform. It's a cuboid-shaped bone, or it's a cube-shaped bone that that makes up the midfoot. So the first metatarsal is here. Second one leads from the second to the second cuneiform. Third one leads from the third phalange to the cuneiform. The fourth and fifth articulate with one bone called the cuboid. Okay, so you've got these long metatarsals. Now if you go to the outside of the fifth, you're going to feel a bony prominence right at the midfoot, and that's the fifth metatarsal head. So we often use that to align the foot quite a bit too. I know it's not listed in your list there, but I like to talk about it because I think it's important to think about what's happening at the fifth toe. Because we want the connection of the fifth toe to the floor. When someone pronates quite a bit, you're going to feel that toe lift up a lot of times. When someone supinates too much, they often lose the connection of the first metatarsal head. So I like to think about those first and second metatarsals in foot alignment. The second and third metatarsals are really important because that's where we want the knee to aim for good alignment of the knee over the second toe in weight bearing and standing exercises. Okay, and lastly we're going to talk about the plantar fascia. So let's show off your plantar fascia. And then pull back. If I pull your toes back like that, I'm going to stretch the plantar fascia, and you're going to feel the tendons here that create an interesting pulley effect called the windlass effect. So when you lift your toes, if you turn your foot to the side a little bit here, if you lift your toes into dorsiflexion, you're going to see that the arch lifts. Intuitively, we'd think it would drop, but because of the pulley system of the plantar fascia and the windlass effect, the arch actually lifts when we dorsiflex. So this is really important in gait and with push-off, so that the foot is a rigid lever when we need it to be in gait to push off, and that with pronation it's a soft bag of bones that can accommodate to the surface during foot flat. So when we're weight bearing on that foot and accommodating to the surface, we need the foot to be fairly loose. When we push off, we need it to be fairly firm. So the foot is a complex and interesting structure. Now we'll find the psoas, and easiest way to do it is to sit in just a slumped, relaxed position, because you want your abdominal wall to relax so you can get in there. You're going to find the ASIS with your fingers here, and then with 2 or 3 fingers, you're going to stick your fingers in and back toward their spine, and then lift the leg. Yeah, that's it. There we go, and you feel the contraction of that muscle right underneath your fingers, and you might have to move around just a little bit to get in there. Okay, good. Any questions so far about those? What we'll do is...
So many questions.
Okay.
Like I can't even like think about them.
Okay, so we're actually gonna, we're gonna sit and do this with each other. We're gonna help you understand how to find these on each other. So you have another 15 or 20 minutes you can play, okay. And we'll find all of these things on you and each other. Let's start by facing the camera. Okay, so now we're going to go onto page 24, the basic postural assessment. We're going to look from the front and the back. And what we're looking for is the height of the ears. I'll get behind her so you can see the height of the ears. And it looks like Christy is a little higher on the left than the right. The height of the shoulders, same thing. She's a little higher on the left than the right. And then we'll look at the space between the arms and the waist. So keep those relaxed so that you can see. She's fairly symmetrical on both sides. However, the shape of the waistline is different on each side. You might notice that. We're also going to look at the height of the iliac crest, side to side, so you can see that. And then the height of the ASIS from the front here. The height of the greater trochanter. This often tells us if we have a leg length discrepancy. And then we'll look at the knee position. Is it normal? Is it valgus, which would be what we call a knock knee position, or is it varus, meaning we have a bow-legged position? And then we'll look at the ankle position. Separate your feet just a little bit, Christy. And then if she's pronated, her ankles will roll in towards each other, so you can show that. If she's supinated excessively, her ankles will roll away from each other. Okay, and then we turn to the back. And we can look at those similar landmarks. We can look again at the ear height and the shoulder height. And you notice that Christy's right shoulder is higher than her left. We can look at the scapula. So we can see the position of the scapula on the back and whether or not the inferior angles of the scapula are higher. And I apologize, she was higher on the left than the right, not the right. She's higher on the left side in the scapula and in the shoulder, and the ear as well. Okay, and the other landmarks, we can also look at the iliac crest from the back side, and we look at the height of the PSIS here. You can look at the gluteal folds as well, and for her, she has a higher gluteal fold on the right than the left. You can look at the fold of the knee, okay, the crease of the knee here, which is also called the popliteal fossa. And you can look at the position of the heel or the calcaneus, looking at pronation, supination, or neutral alignment. So go ahead and pronate, Christy, and so that would be pronation, what it looks like posteriorly, and then supination, what it might look like when someone has a very high arch and maybe calcaneal, either varus or valgus, inversion or eversion. Okay, then we go to the side. So let's look at side view. And from here, we're looking at that plumb line orientation. You see this on page 25, the side view. And here we can see ear, shoulder, hip, knee, and ankle alignment in general is what we want to see. And we look at the head position. So we're going to look, is the head forward of the shoulders? How curved is the cervical spine? Is the shoulder in front or in back or neutral? And then is the lumbar spine too flexed, flat? Is it curved outward? Is it curved inward? Is it lordotic? You know, really looking at the curves of the spine. And you notice that Christy doesn't have a big thoracic curve here. She's fairly flat through the thoracic and has a slight lumbar curve inward. And then we can also see if someone has genu recurvatum, which is also called hyperextension of the knees in layman's terms, and to see if the person can extend the knees backwards. So lock your knees. I usually ask people to lock their knees, and sometimes you'll see recurvatum. Now relax again. Good. And so you can, again, imagine that plumb line going down, and some people actually do hang a plumb line. You can just take a little weight, a heavy pen even, and then hang a string from the ceiling and have the person stand in front of the string to help you with making those relationships between ear, shoulder, hip, knee, and ankle. Okay, any questions about that? Because you want to, you know, find those relationships in your client and be able to see what it is that you want to focus on. So in summary, you're going to write down head, neck, and shoulder alignment. Is the head forward? Is it overly retracted? Is it neutral? Is the shoulder rounded forward? Is it elevated? Is it neutral? Spinal alignment. Is it generally flat? Is it kyphotic? Lordotic? You're going to describe the spine, describing the lower extremities. Are they internally rotated, externally rotated, valgus, varus? Do they have recurvatum? And then also, is the foot pronated or supinated or neutral? And what you want is to kind of see what the person is doing when they're relaxed, not just when they're standing and having their posture evaluated. I like to look at and see what people are doing when they think I'm not looking at them and they're just kind of hanging out and relaxed, or they're just slumped in their chair.
Can you talk about the shoulder from the side?
Mm-hmm.
Just one more time. Mm-hmm. I'm kind of confused as to where.
So if the shoulder is in the right alignment, you're going to see that the humeral head is in a relationship of the shoulder so that it's in line with the ear. Okay? For her, the shoulder is slightly rolled forward, and you can see how the scapula is rolled forward on her back just a little bit, and that there's a little bit of a divot right here. And that's, sometimes the pectoralis minor is a little bit tight there. So what you want is to have the clavicle and the spine of the scapula make a V towards the shoulder, and they should be equal in height.
Your scapula.
Right. It's not about squeezing your shoulder blades together. Yeah, and even less than that. So go less than that, and just let yourself relax again. And now draw the shoulder blades gently together. Yeah, so it's not that. I don't want her to stand around like that. That's what your mother told you to do, and it's good, but it's not great. Okay, so what I want is to have the scapula connected to the back and the humeral head congruent in the socket. So remember,
piece moves back, or
not necessarily.
Not necessarily.
So for Christy, I would like to see her scapula to sit more like that on her back in a relaxed state. So that means I might need to release the pectoralis minor in the front and maybe have these muscles that connect the scapula to the back to be more active. And that's what we're talking about with muscle imbalances. And when you're looking at people, what muscle imbalances might she have? That she has an overactive pectoralis muscle and an underactive either the serratus or the lats or the infraspinatus or the lower trapezius. Okay, could all be a little underactive.
So it's like in the middle of your shoulder.
The other thing that's hard with a flat thoracic spine is that the scapula cannot sit very congruently on a flat thoracic spine. It doesn't have a place to be. It needs a curve outward. So I often tell people if the scapula is winging, it's not the scapula's fault. He didn't mean to. It's because the thoracic spine doesn't have a curve outward. This curve of the thoracic rib cage really is important for the scapula to have a place to move on, yeah, and a place to live. So it's not always because of the scapula that the scapula doesn't sit flat on the back. Okay, good question though. That's great. Okay, so what structures based on that posture that we just mentioned might be at risk for injury? What do you think would be most at risk for injury in her body?
In her body?
Yeah.
Well, her shoulder.
Yeah, so I would say the shoulder is the most at risk. If she's going to do overhead work, or if she does yoga or Pilates with reaching overhead and weight bearing overhead, that's going to be most at risk if she doesn't have the shoulder congruent in the socket and doesn't understand scapular mobility and stability, you know, and that dynamic relationship.
In this situation with the shoulder height,
Mm-hmm.
do you try now to look deeper as to why? Is it a muscular thing? Like, is she tight on her right side? Is that why it goes down?
Yeah, and sometimes it's habitual patterns, and I might notice this, and then I'm going to do the fitness screening to look at other things. So that's going to give me the other piece of the picture, because I don't want to look just statically at someone. I also want to look actively and look at biomechanics and quality of movement. So what tests from the fitness screening do you think would be important to do? The goalpost would be good. What else? The push-up? Yeah. The prone shoulder flexion. I'd love to see how our scapula moves during that exercise. Yeah, so I'd love to see the push-up, the prone shoulder flexion, and the goalpost. Those would be great exercises to look at, or tests to look at in your fitness screening. Okay, and then what modifications might we need to think about if we are trying to protect our shoulder? What would we avoid or change? Not forever, but at first.
Just in general, like with that.
With this shoulder that we talked about, with the rolled forward position of the shoulder girdle, what would we modify?
You want to be careful when you are prone, let's say, swimming exercise.
Yeah, so she might not want to go right into swimming. Yeah, absolutely. What about something like the inverted V or the upstretch? I know you talked about the upstretch with the arms overhead and weight bearing overhead. We might need to modify exercises like that until she has better shoulder congruency and better shoulder position on the body and better scapular organization, which is, we're nitpicking. She looks fantastic, but yeah. I mean, we're talking about nitpicking, 10%, yeah. I mean, again, it's a slightly rolled forward shoulder, but you know, you'll see a lot worse in clients. First thing I'm going to do is do the fitness screening and see what I see.
Yeah.
And we'll decide from there what she needs work on. Yeah, because I can't assume that she can't reach overhead. She might do great with reaching overhead. She might put her scapula in just the right position, and then when she's relaxed, she's not actually in the better position, in the position that I'd like her to live in.
Think of like endurance.
Yeah, I think of posture being how you hold your body 80% of the time. That's really what matters, is that how do you hold yourself upright against gravity 80% of the time? You can probably slump about 20% of the day. But if you slump 80% of the day and you're only in good posture 20% of the day, you're stretching out the structures. They're adaptively shortening based on that poor postural alignment that you're assuming most of the time. So it's like a diet. You know, if you eat healthy 80% of the time and you eat a little junk every once in a while, you're probably going to be just fine. But it's all in moderation. You know, it's where do you live most of the time? in your body. And that's what I'm trying to reprogram with posture, is that I'm not going to change it overnight. I'm not going to get her to walk around with her shoulders back like this, because she's going to have so much soreness and pain that she's probably not going to want to come back to Pilates. That's what your mother said to do. But what I want to do is organize the structure underneath the scapula, underneath the shoulder girdle, to give that optimal environment for the shoulder blade to live. Yeah? Does that make sense?
So you could see a result over how long? A month? How when do you reassess?
I don't know. It might be one session. It might be one session. It depends on if it's structure or strategy. If it's strategy, I might be able to change her postural alignment in one session. So if I did an exercise like the reverse swan, leg pull with the hands from behind, book openings to release that chest, it could be that I could change it in one session. Then that means it's a strategic issue. Yeah, it's the strategy that she's using that's dominating her body patterns. And then if it's structure, if she actually has a restriction, she has a rib that's elevated or rotated forward, or in a structurally disadvantageous position, then I might have to do some treatment to get that structure under control or back to a normal, optimal alignment. And that's what Brent Anderson says is about 20% of the patients need structural intervention, meaning manual therapy skills and mobilization techniques and hands-on techniques to correct alignment. If it's a myofascial restriction or if it's a musculoskeletal restriction, they might need treatment. But really that's only about 20% of people, maybe even less than that. Most people can be helped with strategic intervention, and that's what Pilates teachers do. So I always tell my Pilates teachers that if you're not sure what to do with somebody, then the best thing you can do is teach them alignment, teach them understanding their postural alignment and core control, breathing, and organization, all those principles. Don't come back to me until you've done that with them. And if that doesn't work, then it's probably a structural problem that needs intervention.
How did you help her move her shoulder without moving her scapula?
Because I activated her rotator cuff, which is what the rotator cuff is supposed to do. So face this way. So if I think of the rotator cuff being like a sandwich, actually the sandwich is underneath the scapula, right, the subscapularis, and it's grabbing the humeral head. So I'm going to pretend that I'm the rotator cuff. So if I say, okay, I don't want you to adduct your scapula like that to bring the head of the humerus back. I want you to think of rotating that humeral head back in the socket just a teeny bit, and lengthen here so that this sandwich is lengthening in the front and shortening a little bit in the back. That's how my infraspinatus and teres minor are supposed to work, to hold the head of the humerus congruently in the socket. And most people are so dominant in that anterior aspect, that subscapularis is holding that shoulder girdle forward, the pectoralis minor is holding that shoulder blade forward. And what I want is to allow that humeral head to move back a little bit in the socket. So it's very subtle, and it's really hard not to get these mid-traps to fire, but she's doing a great job. She's not getting those mid-traps firing, so she's keeping those relaxed, and so she's not just adducting the scapula to get the head to look like it's coming back in relation in the socket. So I want that length and that shortening there.
So in her case, you could do a release of the pec minor and
sure.
Opening of the internal rotators?
Sure.
External rotators? External
rotators, yeah. So I could do things like book openings. I could do on the foam roller, the snow angel activities, the goalpost exercise, maybe in supine would be good for her to release this without letting the chest come up. Because that's what happens with the goalpost, is that if someone's really tight there, their rib cage will just come up to compensate. And they didn't actually move the shoulder in relation to the chest. So I want to keep the chest down and keep the spine in a neutral position and really allow that shoulder to move on its own. So that you have to have that lengthening here in order for that to happen.
Mm-hmm. Fair enough. Happens also on the ribs, it happens on the roller. You still also have
to and you might have to put a pillow under someone's head to adjust or to compensate for their lack of mobility at first, because you don't want to just have them lay there with their ribs flared. Yeah? And you work on exhalation, you know, to get the ribs to come down and keeping the chest open as you do it. Okay, good. All right, well done.